Hey guys, welcome to Prasu'S Medledge. I hope you all are doing good and have watched my previous videos. If not, what are you waiting for? Go for those after the end of this video. Now today, without wasting any time further, let's get into today's topic. So today, I'm going to discuss with you nephrotic syndrome. So nephrotic syndrome is characterized by massive proteinuria, hypoalbuminemia, and edema and hyperlipidemia. So these are the four features which you will be seeing in nephrotic syndrome. Heavy proteinuria is leading to hypoalbuminemia. The resultant fall in plasma oncotic pressure leads to interstitial edema and hypovolemia, which we see in nephrotic syndrome. Hypoalbuminemia also induces hepatic synthesis of beta lipoproteins, which results in hypercholesterolemia, seen in nephrotic syndrome. Now, nephrotic syndrome in children can be divided into two groups based on renal histology. So, one is minimal change nephrotic syndrome, and other one is nephrotic syndrome with significant lesions. So, steroid sensitive nephrotic syndrome, that is basically minimal change nephrotic syndrome, has a satisfactory outcome after the treatment with drugs. So, let us first start with steroid sensitive nephrotic syndrome. So, in MCNS, that is minimal change nephrotic syndrome, renal biopsy doesn't show significant abnormalities on light microscopy. But on electron microscopy, non-specific obliteration of epithelial food process is being seen. Now coming to the clinical features, the onset is insidious with edema first noticed around the eyes and subsequently on the legs. It is soft and pits easily on pressure. Gradually the edema becomes generalized and there will be associated ascites and hydrocele. Then urine output may fall. After the loss of edema, severe muscle wasting is revealed in case of nephrotic syndrome. In nephrotic syndrome, infections may also be present. Now coming to the laboratory findings, urine examination shows heavy proteinuria, that is 3 plus or 4 plus. Then serum albumin will be low as it is lost in urine. Then C3 levels will be normal. Complement levels, that is C3 levels, will be normal. Now coming to the evaluation at the onset of nephrotic syndrome. So it basically includes urine analysis for proteinuria, red cells and casts. Then blood levels of urea, creatinine, albumin, cholesterol. Then complete blood count, tuberculin test. Apart from this, additional tests which we should do are C3 and anti-streptolysin O levels. Then we have to do a chest x-ray in case we are suspecting a tuberculosis in the patient. Then anti-nuclear antibodies have to be looked for if we are suspecting systemic lupus erythematosus in the patient. Now coming to the management of the initial episode of steroid sensitive nephrotic syndrome. The child should receive a high protein diet. The salt is restricted. If there is any associated infection, it should be treated. Patient should be screened for TB. Diuretics administered if edema is significant. Now coming to the therapy with corticosteroids, the first episode of nephrotic syndrome should be treated adequately. So in corticosteroids, we have either prednisolone or prednisone, which is given at a dose of 60 mg per meter square per day in single or divided doses for 6 weeks, followed by 40 mg per meter square as a single morning dose on alternate days for the next 6 weeks. So total duration of 12 weeks. Now coming to the definitions which are important regarding the course of nephrotic syndrome and are very much asked in university exams. So let us see those definitions. First is remission. When do we say remission? When the urine albumin is nil or trace for 3 consecutive early morning specimens, then it is called as remission. Coming to relapse, that is urine albumin 3 plus or 4 plus for 3 consecutive early morning specimens having been in remission previously. Next is the frequent relapses. Frequent relapses means 2 or more relapses in initial 6 months or 4 or more relapses in any 12 months after the 12 weeks of treatment for nephrotic syndrome. Then is steroid dependence, that is 2 consecutive relapses when on alternate day steroids or within 14 days of its discontinuation. Then steroid resistance, absence of remissions despite therapy with daily prednisolone at a dose of 60 mg per meter square per day for 4 weeks and alternate day for next 4 weeks. So these are the definitions which you must be very thorough with because this can be asked separately in exam. Now coming to the management of relapse, that is done basically by prednisolone. Sometimes we can use the steroid sparing agents. This should be considered when there is any feature of corticosteroid toxicity. The agents which we use here are lebimazole, cyclophosphamide, cyclosporin, tacrolimus, and rituximab. So try to remember any three out of these. Now coming to the complications of nephrotic syndrome. So first is edema. It is usually controlled with salt restriction and oral hydrochlorothiazides or furosemide, that is basically diuretics. Then infections, nephrotic syndrome and steroid therapy renders the child susceptible to infections. So child can usually present with several infections like peritonitis, pneumonia and meningitis. Now coming to the other complications, that is thrombotic complications, that is patients are at a risk for thrombosis involving the renal, cerebral veins, etc. Then other complications are hypovolemia and acute renal failure, then steroid toxicity because of usage of corticosteroids. It is usually characterized by cushingoid features, short stature, hypertension and subcapsular cataract. So this was all about the steroid sensitive nephrotic syndrome. Now coming to the steroid resistant nephrotic syndrome. So in steroid resistant nephrotic syndrome, baseline assessment of renal function, blood levels of albumin and cholesterol, and estimation of proteinuria guides the evaluation. Children with steroid resistance should undergo renal biopsy before instituting the specific treatment. This is a very important statement. They should undergo renal biopsy. Patients should also undergo testing for hepatitis B surface antigen, then anti-HCV, IgG, and HIV. Now coming to the management, most regimens use a combination of an immunosuppressive agent with prednisolone, which is given on alternate days, and an angiotensin converting enzyme inhibitors. Okay, so the use of IB albumin is indicated only in few cases. In case of the steroid resistant nephrotic syndrome, that is mainly in symptomatic hypovolemia, symptomatic edema, and in case of marked ascites, which is causing respiratory discomfort or compromise. Now a word about congenital nephrotic syndrome. Congenital nephrotic syndrome present in the first 3 months of life with anasarca, that is generalized edema, then hypoalbuminemia and oliguria. The therapy of the patients with congenital nephrotic syndrome includes mainly appropriate nutrition, then control of edema and reduction of proteinuria. Along with that, we can also give thyroxine supplements. So with this, we end the discussion of congenital nephrotic syndrome. Now you can take the screenshots. So here massive proteinuria, hypoalbuminemia, edema and hyperlipidemia is important. Then edema and hypovolemia is important. Then hypercholesterolemia. Then there are two types, as you can see, minimal changes and with significant lesions. Then steroid sensitive nephrotic syndrome, you should know the clinical features. You should know about the edema, then urine output, then loss of edema will reveal severe muscle wasting, then infections can be present, then laboratory findings, you have to be thorough with laboratory findings, then evaluation, which I have already mentioned, then management of the initial episodes. So here salt is restricted, then child should receive a protein diet, high protein diet, that is any associated infection should be treated, and the child should be screened for TB. And this is very important, the dose of the corticosteroid which we are using, that is prednisolone or prednisone. So what is the dosage that is initially we are using for the first 6 weeks, 60 milligram per meter square per day, then for the next 6 weeks 40 milligram per meter square per day. And there's the definitions regarding the course of nephrotic syndrome. This is also quite important. Regarding the management of relapse, you need to know only prednisolone and the steroid sparing agents. Then complications of nephrotic syndrome, then steroid resistant nephrotic syndrome, and finally congenital nephrotic syndrome. So with this we end the discussion of nephrotic syndrome. I hope it was useful for you. So please do like, share and subscribe to my channel, and if you find any doubts, you can always ask me in the comment section, and please hit the bell icon also to get the notifications whenever I post a new video. Thank you.